Nice to see so many people online. I have to say, this is the new norm for me, speaking to everybody online. And I think most of us spend our time now as professionals speaking online or through video or telephone from morning till night, because that is what we need to do. And what I'm going to plan to do now is accepting that, you know, these are extraordinary times. We don't know how long we're going to be going on like this for, is try and give a brief presentation about where we think we are with COVID-19 in relation to epilepsy and Dravet syndrome, with some specific advice, and then talk a little bit to the questions that have already been posed. And then hopefully there'll be the opportunity for people to be able to pose more questions if they so wish through the chat function. So what I'm going to do now, she says, looking for it, is share my screen with regard to some slides. And for those of you who may be on phone and not on Zoom and can't see the slides, we are going to share the slides following, so people will be able to do this. But it just gives, I'm going to talk, I'm not going to say anything particularly that's not on the slides, so I am going to talk through it quite carefully. So there has been a lot of anxiety with regards to anybody with epilepsy in this pandemic. I think first thing I do is put up the graph, the map of the world, to show really there is no real, no country that is not affected, however much world leaders may say, by this pandemic. And those countries that do not appear to have reported the case are probably unaware of the cases, rather than actually that there are no cases present. So we are all affected by this. So what I'm going to talk about are the three main areas. The main areas that have been of cause of concern are the possible direct effect of the virus. SARS-CoV-2 is the name of the virus that causes the illness COVID-19, and what possible effect does it have on persons with epilepsy? Are persons with epilepsy per se at any greater risk from the disease than others? Then I'm going to move on to talk about how we're trying to give advice about keeping people with epilepsy, and particularly the complex epilepsies, safe concerning the severe disruptions in clinical service, and then overall general advice and guidance as to where to find further information. So what about the actual virus? Does it have a predilection for actually the nervous system or not? What it causes is specifically a respiratory illness, and most of the severe disease is because of the effect on the respiratory illness. And what we have to bear in mind is the vast majority of individuals who have this virus or are symptomatic for this virus have a mild disease. The problem we have is predicting who has a mild disease and who may go on to develop severe, more respiratory problems. The question for neurologists and people like me is has it got a predilection for the nervous system? Could it cause any further problems? What we've determined is that's probably not the case. If we talk about to countries like China and Italy, and when we look at the data that they are producing, it appears that individuals with epilepsy, even the more complex epilepsies, are not more likely than others to be infected by the virus, nor are they more likely to have severe infections. Those that are high risk are those that have mobility restriction disease, and by that I mean impaired mobility, so they are not freely ambulant as other individuals. Those that have respiratory conditions, including asthma, impaired immune function, either because of a disease of the immune system or because of drugs they are receiving, such as steroids. Underlying, whether they have diabetes, and most of this is type 2 rather than type 1 diabetes, so we're not talking about the type that comes on in childhood. Cardiovascular disease, including hypertension, and older age. And of course, older people with epilepsy may have these as comorbidities, some younger do as well, but many older people with epilepsy have these as comorbidities, and that may mean they're a bit more at risk of a severe disease. Children appear less likely to suffer severe respiratory illness than adults. In China, it appears that only 0.9% of those that have been admitted with a severe illness have been between the ages of 0 and 14. and only 1.5% in those in Italy have been under 20 years of age. So children do not appear to get the severe illness as adults, and it is older age and as you approach post 60, post 70 that they're more at risk of getting the severe disease. The other concern has been the issue that there is a very high fever, of course, at the presentation of symptomatic COVID-19. But there's been no reports out of those countries that have had the more severe pandemic to date that there is an exacerbation of seizures in this population that's required admission to hospital over and above what would be seen anyway. And that may be related to the fact that it's not affecting children to the same degree, and you're more likely to be fever sensitive or illness sensitive if you're younger with Dravet syndrome. So there are lots of confounders, but it does not appear to be putting lots of individuals with complex epilepsy into hospital. As I talked about before, one of the questions that we have is that could the virus itself have a predilection for the nervous system? And certainly the way it invades the body and the way the basic scientists have determined it invades the body, in theory, it could go into the nervous system. But it appears that if you look at the vast numbers that have had the disease in China, in Italy, and now in France and Spain, they don't appear to have an exacerbation of seizures early in the phase of the disease. And it's only that seen in the end stage of the disease and very severe disease that might see seizures, whether it's related to lack of oxygen, whether there is an encephalitis in a very small minority, but it does not appear to be a primary neurological problem. It's primarily a respiratory disease. Although there does appear to be headache as a presentation of it, but it is headache, it's not more than that. The other issue then comes on to symptom control. What if my child or my child does get COVID-19? What can we do? And one of the things that have been circulating is how we control fever. Of course, in Dravet syndrome, that's something that's key. We want to control fever to minimize the risk of seizures. And there has been some information circulating that ibuprofen may increase the virus load within individuals and therefore make individuals more likely to get severe disease. I have to say the evidence for this is growing thinner by the day. There is no convincing evidence of this. And although there's a recommendation that perhaps paracetamol be used in the first instance rather than ibuprofen, if it's a case of getting the fever down, I think the issue is we use what we're used to. And as I said, there is very little evidence now to suggest that ibuprofen can increase the severity of the disease. There are other medications such as decongestants that are now, we know may aggravate seizures in some, and therefore they wouldn't be recommended, although congestion is not a particular symptom as far as I'm aware of COVID-19. There is also some emerging evidence of antibacterial and agents that may be utilized and may be successful in reducing viral load. And although, for example, chloroquine, which is an antimalarial, in fact, has been put out by the WHO to be not used by individuals with epilepsy, the evidence that actually aggravates seizures is quite slim and variable. But what we are putting out to physicians is that if individuals with epilepsy need to be admitted, particularly those with complex epilepsy, then we need to be aware of medication interactions. So some of these drugs have interactions with medication. And in fact, although there's been a statement that there's no interaction with cannabidiol, Zogenix has put out that there may be an interaction with fenfluramine, reducing its efficacy and therefore making it possible, in theory, aggravation of seizures, and stiripentol, it's really not known. So the issue is it just needs to be stated that they're on that, and if those medications are going to be used, caution expressed. So one of our main focuses really as an epilepsy community is to try and keep individuals out of hospital where possible. And the reason for this is the fact that the burden of disease, it's the rapidity of the numbers of people being admitted to hospital, the burden on our healthcare system, and so to try and minimize the burden on the healthcare system from anything else, but also the fact that if you go into hospital, you may come into contact with individuals with COVID-19, and therefore we want to minimize the risk to those individuals who go to the hospital and also to those around them. So the issue is to keep people out of the hospital setting where possible. And most of us have now moved to telephone clinics or video telephone clinics, whether it be new patients or follow-up. In fact, with the epilepsies, I'm not sure why we don't do more of this, because there's a lot we can do over the telephone. Yes, there's something we have to do if there's a new change of seizures or new emerging neurological finding we want to examine, but that we can usually utilize with video. And if you're concerned about a change in seizures, the best thing is to video it and send it in to your doctor rather than actually us to examine them anyway. And the other thing we're trying to do is minimize the need for investigation. We are not doing routine EEGs in our hospital. We are doing emergency EEGs where required. There are very few circumstances, particularly in Dravet's, that we would want to do a routine EEG, and this can probably be postponed unless there's a concern perhaps about non-convulsive status until this crisis is over. The only need for do imaging, again, would be if there was new pathology and we would be worried about something emerging that we could treat, but in the vast majority, MRI can be postponed in addition. The other things we can do, and we can do this as individual families as well as doctors, is ensure that up-to-date emergency care plan, that emergency care plans are up to date. The threshold to utilize emergency rescue medication may be lowered. We may use it sooner than perhaps we would otherwise, although in many with Dravet's, there's a sooner than the 5-minute rule anyway. And indeed, we want to make sure that there's careful discussion about when an individual might need to go to hospital, you know, and also where. I know that one of the questions that's been asked is, where should we go? I think the issue needs to be discussed with local epilepsy teams about, to be clear on emergency care plans, what is given and indeed when a hospital admission might be required. And that, of course, may need to happen if the seizure doesn't stop despite the emergency medication, if they don't wake up in the normal way that they would normally, or if there's injury. But in you know, where they go also needs to be clarified to go on that emergency care plan. We also need to make sure that we do have a regular supply of medication. And I think one of the concerns I've had from my patients is how can we make sure of that, especially with medications that are only available from the hospital. And we are providing repeat prescriptions. There's been a concern about should we have this longer than the usual 3 months. We're discouraging stockpiling medications. And also what we've also done, however, is make sure that the medications can be couriered. And this includes now cannabidiol from Great Ormond Street Hospital. That's what we have done. Previously, controlled drugs could not be delivered, sent or couriered. That has been changed in the last week in our institution, and I presume others. And also with regard to clinical trials, which I'll come to shortly, we are also arranging for medication to be couriered out to families rather than then having to come into the hospital to pick it up. We've currently got no evidence of a shortage of supply of medication. One positive side of Brexit is that there was we had ensured apparently that we had enough medication for a period of time. So actually, you know, there is no concern about us running out of medication at the present time. So overall, we should be just going for our standard prescriptions, but making sure we let people know where we get our prescription from in plenty of time so that a repeat prescription can be provided. And, you know, I don't think this would occur, but what we've tried to say is that any change, whether it be a wean because of seizure freedom or seizure improvement, or a wean because other medications have improved the situation, will probably be postponed or even held in this time where if things do deteriorate, it's very, you know, we'd rather patients didn't come to the hospital, and therefore we want to leave things stable where possible. The clinical trials, I was asked specifically to talk about. This particularly relates to Zogenix fenfluramine trials, and we have been given permission by Zogenix to undertake remote consultations as long as we go through the appropriate questions and we make the appropriate documentation. And as I've already said, medication to be prescribed and up to 6 weeks supply given but couriered out to families so they don't have to come in. Then there's the concern, of course, about echocardiograms. And we have had confirmation that if the previous echocardiograms have been relatively normal or less than a trace of mitral regurgitation, then we can delay the echoes 3 months. And if they're transitioning onto the more longer term open label study, then it may be delayed by 6 months. So then if the previous echoes have been relatively normal, then we can postpone them. There's no reason why it's suddenly going to become abnormal over the next 3 months. Obviously, there may be individual cases, and we are dealing with those on an individual basis and trying to bring them in for echoes under the safest conditions possible. Laboratory investigation, we've been told, can be delayed up to 6 weeks. They can be conducted locally if clinically indicated, or if delays are expected to be more than 6 weeks. And that we will discuss on a case-by-case basis. One of the other major discussions is how much isolation is required. Now, I think we have to take into consideration how vulnerable individual patients might be, and that may vary according to whether they're very young or quite senior in their age. What we're trying to do is minimize the chance of transition. Of course, we want to minimize the chance of infection, but we're also trying to minimize the chance of transmission. And there's the issue about complete isolation versus social distancing. And I think in the vast majority of my patients with Dravet syndrome, I would suggest that what we call strict social distancing is appropriate and sensible precautions taken. Complete isolation means staying in the house and not venturing out. And I appreciate that that may be incredibly difficult for many families with quite challenging children with Dravet syndrome. And I think a walk to the park and walk back again with very little, if any, contact with anybody else is completely fine. You're not going to get it from going out in the fresh air. The issue is contact with others. So being sensible about the walk, when you do the walk, when you take them to the park, not getting in close contact with other individuals is the key common sense rule that we have to take. The other thing is, if you've got somebody in the house who's coming and going because they have to go to work, for them to come back, change, even shower, wash their hands before they have any interaction is the appropriate thing to do. It's trying to minimize the chance of bringing the infection back into the house. Some of you have carers coming in and out, and they will have had their own instruction and precautions, and there are instructions by the government on what should happen. And the main message is for them to take PPE precautions when they're dealing with the individual children, and if they need to self-isolate if they come in contact with symptomatic individuals. And there's also been the government advice about schools, about the issue about vulnerable children. Those with an EHCP should maybe continue to go to school. But again, this needs to be dealt with on a case-by-case basis. The minimal chance of your child getting the infection is by keeping them at home. But of course, there is a balance to be had in view of the fact they may have behavior, may need problems, they may need routine. What sort of instructions have been given by your local schools, what is available, and therefore that needs again to be considered on a case-by-case basis. Mental health at a time like this, well, mental health I know is an issue, not just with the children, but with the families as well. We've got highly challenging children, and mental health issues are prevalent in any case. And actually there have been some studies already, particularly amongst the Chinese population, mainly amongst individuals with epilepsy rather than their families, but actually most of the concern was around sustained medication supplies rather than the individuals. But I have to say, if you've got a child with very complex needs, then being at home with them the whole time, having to be on a one-on-one with them the whole time, when at times you have breakthrough school, can be highly challenging. There's no doubt that there's a lot of online support which can be utilised. I'm going to give some links, I think they're in the next slide, which we will provide. The top links that I've got on this slide are to do with further information that can be acquired over and above what we have from our government anyway. The bottom ones are all about wellness and well-being, and essentially seeking help online as to what to do. And it's about a case of making space for yourself, being able to talk to others, and also doing what's right for your family within the individual setting. And I think this is a difficult time. We all find it a very challenging time. And what we need to do is realise what we need to do is what's best for our family and our individual child, and try and keep things also in perspective. We see everything on, when you're constantly watching the TV and watching the news, watching the death rate, it seems absolutely horrendous. And there's no doubt it is, and highly tragic for the families that it is occurring. But relative to the number of individuals who are going to be infected with coronavirus and have COVID-19 disease, it is not a high number. The issue is that it's escalating at a higher rate. It's presenting a high burden, and that's the problem that we have on our NHS services. What I will do now is go through some of the questions that I've had. So there are a series of questions that have come through, and some of them I've dealt with and some of them I haven't. I think the social distancing I have talked about, and there's no doubt that to walk to the park without coming into close contact with others is absolutely fine. And I've also talked about if one having to go to work and advice about how that should occur. I've also talked about the couriering of the medication. We don't expect people to come to our hospital at Great Ormond Street Hospital to pick up their medication. It is all being couriered, whether it is a trial medication or whether it's CBD on the normal prescription. I also talked about the fact that the emergency care plan should perhaps have some discussion about at what point hospital attendance is required and where. There is a question about a boy being 16 and in transition, and whether it would be best for him to go to paediatrics or adults. I have to say, at 16, there's no difference between the ventilator at 16 there's no there's only a very small chance the disease would be severe enough. The issue is if the seizure doesn't stop, of course, and therefore it requires admission to ITU. And I think the issue is if you go to an A&E department, they will be separating out as to those who have COVID symptoms and those who do not for other reasons, and they will have separate areas for example, seizure-related admission as opposed to COVID-related admission. So there will be separation, albeit it will be a similar care pathway. And again, on an intensive care unit, there will be divided areas. Another question I have is about the fact that, if a girl has profound autism and anxiety in association with her Dravet and won't tolerate EEGs, blood tests, or any interventions. I think the issue is if they've not previously required help with their ventilation, there's no reason why a Dravet child should not be put forward for that if they require it. And you have to remember that actually if they require intensive care, they are not likely to be the same highly busy, anxious individual that you have on a day-to-day basis. They're going to be actually sedated to some degree because their respiratory rate is not good. So I don't think you can mark how they are with an EEG as to how they would go if they need intervention. The likelihood of them needing respiratory intervention is small, but each one will need to be considered on a case-by-case basis as to what level of intervention is required and how that happens. And that the medical team will do if it's required. There is a question about Pseudomonas on the chest affecting Dravet syndrome. I'm not sure whether this question relates because a child has Pseudomonas or they're worried about them getting Pseudomonas after. Pseudomonas is a bug that can populate the lungs when you've had chronic disease, and typically it's seen, for example, in children who have cystic fibrosis, when they've had a lot of chest intervention, they may get this bug, and that can be quite problematic. But there's no reason why it's going to happen if an individual gets COVID-19, or whether, particularly if there's no pre-existent chest disease. So I wouldn't be particularly concerned about that. A diagnosis of unsafe swallow is usually made when there's concern about swallowing. There will have been a history of a lot of coughing and choking on feeding, and if they can swallow without coughing and choking and swallowing and eating a normal diet, then it's unlikely that they have an unsafe swallow. And the only reason for putting unsafe swallow in the reason for being perhaps at a higher risk of disease because of the possible recurrent aspiration. So chest disease as a result of recurrent aspiration is more likely to put them at risk than the unsafe swallow per se. In the ABN, the Association of British Neurologists guidance, fever-related epilepsies have been classed at low risk. By this, low risk for gaining a severe disease. That is what the low risk means. So as I said, we have no evidence that individuals with complex epilepsy are at a higher risk of severe disease unless they have associated comorbidities. So that's why the ABN have listed it as low risk. Then to move to some other questions that have come up on the group chat. Would I suggest increases to medication on CBD where 2 weekly blood tests are needed are temporarily stopped? I would suggest that medication increases that require an assessment like that would be postponed, yes. I hope that the postponement is only going to be 4 to 6 weeks, but I would suggest that if further blood tests are required, we try and avoid those. And if they've been stable on a set dose of medication, then that is maintained, unless, of course, there is an exacerbation of seizures and there's a real need to consider a change of medication. And there's a question about asthma, severe asthma, and severe asthma would be listed as a high risk. So it's not, again, that the Dravet syndrome is the reason for isolating an individual, but the severe asthma would be the reason for trying to avoid him getting the virus in the first place. That is the end of my presentation, and I hope I've answered the questions. Oh, hang on, we've got more questions. That's fine. Okay. There is an issue where children are from houses that they live across 2 places. And the question is, can my child go to her dad's once a fortnight? He is social distancing strongly and has type 2 diabetes. And I think the issue is if people are being very careful and, you know, he is social distancing, he obviously is at higher risk because he has type 2 diabetes. So again, if he's isolating, if he's not mixing with people on a regular basis, I can see no reason why she shouldn't go to stay with him. The issue is again, of course, all the cleanliness, all the hand washing, all the making sure we minimize the risk. But actually, if he is already strongly social distancing and trying to maintain avoidance, then there's no reason why not. Again, I think it really has to be, you have to have a risk assessment. And I think, you know, there's the balance of the families needing a break versus the risk of getting the virus if you go into respite. I know that many of the respite perhaps will have, they will have instituted their own process by which they need to minimize infection. I suspect they will have been keeping individuals in their own rooms. They will minimize the number of staff that are going in to look after them. And then that's probably a conversation that each individual has to have to weigh up the risk and weigh up the likelihood of infection. But everybody is trying to minimize that and accept that in certain circumstances, these stays are required. You know, there are still children with terminal disease, for example, who need to go into such places. But again, you know, in particularly hospices, but, you know, again, we have to weigh it up on a case-by-case basis. What processes have been put in place by the centre? It's likely that they've put a lot of processes in place to try and keep their patients safe, and staff, I have to say. No, having a button or peg does not add an additional risk. In fact, obviously that reduces the likelihood of aspiration and chest disease. But no, it doesn't add, as far as we're aware, an additional risk. It's more likely to, it's whatever may predispose to a chest disease or cardiovascular disease, and the cardiovascular disease is in the older population, not the children. There's an issue about regarding the question of the 12-week isolation issue. Is Dravet syndrome alone considered low risk unless or until there are other diagnoses which complicate the general condition? And that is exactly right. We haven't got any evidence that having a complex epilepsy such as Dravet syndrome poses a greater risk of severe disease. Now, that's what we're saying. Everybody is at risk of getting the infection. I have to point that out. We're all at risk of that, and we could all contract the infection. The issue is who is at risk of severe disease, and we haven't got any evidence that those with complex epilepsy, if there isn't a comorbidity of respiratory illness or respiratory disease or cardiovascular disease or old age, of having a greater risk of the severe disease. And also, as I mentioned at the beginning, and they may have been missed, you know, the number of children getting severe disease is proportionately very low. As I said, 0.9% under 14. 0.9% of the severe illness population were under the age of 14 in China, and 1.5% under 20 in Italy. So, you know, children do not appear to get the severe disease, and even those who do have got other underlying conditions such as immunosuppression or respiratory disease that may predispose them to that. If she's not had recurrent chest infections, probably not, no. And I think the issue also is how old is she? And if she's under the age of 30, again, the likelihood is no. So I say mobility restricting may put you at higher risk, but that's again because that can predispose you to risks of chest infections. The issue is if they're prone to recurrent chest infections, that might, and I'm saying might, make you at risk of a more severe disease. Oh, here we go. Our child already has Pseudomonas from a previous intubation in lungs. Would she be classed as high risk? It's more to do with the associated chest disease rather than the bug itself. And the fact that she has Pseudomonas from previous intubation, I presume that she may have, I don't know whether she's got underlying chest disease. If there's no underlying chest disease, then not necessarily. But if she needs recurrent suction, she gets recurrent chest infection, then that may pose a greater risk of severe disease. If that was a one-off related to the swine flu, not necessarily.
Right.
You know, it's not the same, you know, just because they develop pneumonia as the result of the swine flu doesn't mean to say it's going to get pneumonia as a result of this. It is a different disease, and the way it affects the body is different. So I don't think if it was a one-off, it's going to make you more high risk. But of course, it does need to be better. If he gets flu at other times and tends to go onto his chest, then that may be a bit of a concern.
Thank you, Helen. Well, thank you, Helen's. Both Evans, Helen Evans, our director, for organising and facilitating this, and a big thank you to Professor Helen Cross. I think that's been really, really helpful, and I can see there's lots of people thanking you on the chat, but it's really reassuring, and I think it's very nice to hear directly from a professional who can give us some advice about what we specifically do with Dravet syndrome, because there's a lot of stuff flying around, which is very, very scary for us all. But it's been really, really helpful. So thank you so much.